Hello everyone and welcome back to Dysphagia Matters. I'm Julia.
And I'm Jule. Thanks for tuning in.
Today's topic is something that has been at the very top of our must-cover list for a very long time.
Exactly. We are very happy to talk about functional dysphagia today. As clinicians, we all know those cases where a patient experiences very real and severe difficulties with swallowing, but every objective assessment comes back normal.
For years, these patients probably were often dismissed as quote-unquote purely psychogenic. Our guest today is changing that narrative by providing a new structured framework for our field.
We are thrilled to welcome Professor Anna Miles from the University of Auckland, New Zealand. She is a leading researcher in the field of dysphagia and joins us today to discuss her new paper on this biopsychosocial approach.
Enjoy listening. Welcome to the Dysphagia Matters podcast, Anna. We are so happy to have you with us today.
It's lovely to be here. Thank you for inviting me.
In your paper, Functional Dysphagia, Developing a Framework for Assessment and Treatment that you published with your team, you write that you prefer the term functional dysphagia over older labels like psychogenic dysphagia or phagophobia. Why is this distinction important for clinicians and patients?
I think it's really important. Labels matter. They guide clinicians and health services on the type of intervention to provide, but they also empower patients. If a patient doesn't have a label that they can research and a label the same as other people that have similar problems, it's really hard for them to believe in what they have. And these patients often have been around the houses and had a lot of investigations with different specialists. So each specialist using a different word doesn't help them. And I sort of came to this with my own caseload and what I was going to do with my own patients. I was receiving referrals with different labels, hypersensitive larynx with food aversion, psychogenic dysphagia, NAD, instrumental assessment, please see. Everyone came with a different term and none of them were coming to me from neurology. They were coming from gastroenterology, ENT, or from the community self-referral, not from a neurologist like I would see when I see functional speech disorders or functional stroke when I worked in acute care. So they were coming from all different places with all different labels, and I didn't think those labels fitted what I was seeing, but I also thought it wasn't helpful for a patient to not know a diagnosis, not to be given a term that they could use.
Yeah, absolutely. And how do you think does the proposed biopsychosocial framework differ from the traditional medical model in its approach to the quote-unquote unexplained swallowing complaints?
Yes, I think the biopsychosocial framework that is really well established in functional neurological disorders more broadly is really helpful because it gives us an opportunity to look at the patient's full array of presentations and then tailor the therapy to suit each patient. I think these patients are some of the most complicated I've ever seen in my career. I think they're more complicated than when I worked in major trauma, neurosurgery, head and neck cancer. They're a really complicated group and their symptomology isn't just phobia. And the framework, using that biopsychosocial framework, allows us to unpick the full extent of their problems. Yes, it has the typical fear, phobia type part to it where they have emotional regulation, emotional processing challenges, extreme beliefs about their risk of choking and their risk of not being able to swallow their saliva or what their swallowing is like compared to normal. But they also have aberrant motor sensory changes that are really different from our other patients. Hypersensitivity to saliva, hypersensitivity to the feeling of food going through the throat, the sort of hypervigilance and muscle tension that we often see in these patients. And then they have this sort of section of behavioral consequences, the avoidance, the compulsive behaviors, the multiple chewing or multiple swallowing of water to wash things down, and avoidance behaviors that, again, need to be addressed in therapy, so need to be part of that model of assessment, or we're not going to treat the whole person, we're only going to be treating a part of them.
And so you said this group of patients are very complex, or their dysphagia is very complex. What would you say are the most reliable red flags for clinicians that distinguish the functional dysphagia from structural or neurological causes?
I think that red flag, or as they say in the functional neurological disorders, positive signs, is really critical because it takes us away from diagnosis through exclusion. So we give them an instrumental assessment and it comes back as normal. And so the patient is left feeling like they were told, oh, don't worry, it's normal, when of course it's not normal for them. It's extremely impaired. They can't swallow. They've been told it's normal or it's in your head, which is really disempowering and upsetting for a patient. Whereas going by positive signs allows us to look at the patient's symptomology, the history of adverse events, so strangulation, choking, prolonged intubation may be part of the story, but it's not all of it. The absence of an instrumental assessment finding or a real incongruence between instrumental and the extremeness of what they tell you is another positive sign. Heightened sensation or heightened muscle tension. Variability, they often describe distraction, or when I'm relaxed or when I have a drink, my swallowing is better, which we don't see with our other patients. Our other patients are better when they focus and worse when they're tired. So that's a really nice red flag or positive sign that something else is perhaps going on. I think their distress is often heightened. They show really, really high patient-reported outcome measures. You know, they're giving themselves 40 out of 40 on the EAT 10 without having to think about it. Absolutely, that's where I sit. And often we see positive signs of quite selective food avoidance. I can't eat yogurt. It sticks, but I can eat a burger. So it doesn't quite fit the picture of what they can and can't do. I think we often see that hypervigilance, so a real focus on swallowing mechanisms, swallowing feeling, swallowing passing. I can't trigger the swallow. I can't get it past this point. It feels like there's a lump right here. And of course, we see huge nutritional concerns, but perhaps in the absence of respiratory concerns. Right. So I think these are all positive signs that mean we don't need to go by no instrumental assessment alone, that's not a good way to diagnose. We need to diagnose with what they do show, not what they haven't shown.
And are there typical foods that are more complicated for those patients, or is it just an individual issue?
I mean, this is just my own clinical experience, and I know everyone will have similar stories. And the more I talk about it, the more I hear everyone saying, yes, me too, that's what I see. But yes, I think we see things that would be typically of a sensory nature. So things that are sticky, they really don't like, perhaps, but also the hard and crumbly and scratchy. So things that will give you a particular sensory response. But it's very tailored and individualized. I think different patients will tell you very different stories, with some patients not managing solid food at all and only managing fluids, and some people really struggling with fluids and struggling with triggering a swallow on fluids. So I think it's a much more individualized description of what foods they find hard and easy compared to stroke, where we expect to see something, and as soon as it's solid dysphagia and not liquid dysphagia, we start to wonder if it's something else. And so it's got less of that patterned description that we would normally see with our patients with neurogenic dysphagia or esophageal dysphagia.
Yeah, that makes sense. In your paper, you defined functional dysphagia as a loss of voluntary control or altered sense of agency. Can you maybe explain how this neurobiological perspective changes how we then view symptoms that were previously dismissed as just psychological?
Yes, I think loss of agency is really interesting. It's a really key feature of functional neurological disorders, FND. And the concept is that patients are not voluntarily avoiding swallowing. It's not a voluntary act. It's a loss of control of their ability to trigger a normal swallow motor response. They can't swallow. They mean it. And I think that's really important compared to saying it's all in your head, which unfortunately our medical model taboo against mental health sees in a very different way as being something that someone's being a fussy eater, they're being difficult. If they really wanted to, they would, but they're avoiding doing it. So I think this concept of loss of agency really empowers patients, because we're saying, I know you can't do that, but let's work out how to enable you to do it. In the FND literature, they'd call it, to patients, they will describe it as a software issue, not a hardware issue. So the instrumental assessment showed us your hardware, and it's great news that your hardware is fine, but we've got a software connectivity issue that we need to work on. But now we know that's what it is, we can work on it. So really empowering the patient to feel they were heard and understood, and they're not making it up and they're not doing it on purpose is really powerful.
That's very interesting and a great metaphor, and really changing how we approach these patients. Your paper also mentions MRI findings showing increased functional connectivity between motor control centers and the limbic system. What does this tell us about the relationship between emotional processing and physical swallowing function?
I think this is really interesting, isn't it? It doesn't come from functional dysphagia literature. We have very little on functional dysphagia. It comes from the FND literature more broadly. But what they've found on fMRI is that there's an increased functional connectivity between the motor cortex, so the motor control centers, and the limbic system. At rest, but even more so during trigger tasks, so the things that person is particularly struggling to do. And I think it sort of brings us a little bit closer to understanding that sensory motor aberrant response that we're saying our patients have, the hypersensitivity, the muscle tension, the closing up of the throat when they go to swallow. If our limbic system's lighting up alongside every time our motor system does, and it's even lit up in preparation or thinking about doing that act, of course it's going to affect our finely tuned, perfect motor sensory coordination of a swallow. It's interrupting the swallow with all this extra noise that is not a noise for high function motor function. It's a noise for alert and worry and distress. And we all know that we don't function very well when we're very distressed and stressed. So I think, although we're having to make some judgments of our own about how that might affect swallowing, it does give us a little bit of thought around what could be happening for these patients. And I often use it when I'm talking to patients, and I say, what's happening is the part of your brain that's all ready for stress and fight and is there to help you when things go wrong has decided to kick up and do things when it shouldn't, and that's really affecting you from functioning. So no wonder your swallowing is troubled. So helping the patient to understand what it is that might be happening for them, and therefore giving them an answer, giving them the education and the belief in something. I think they just need something solid to say, this is what I've got, so that makes sense to them.
Yeah, and I can imagine they've heard the sentence, there's nothing wrong with you, a couple of times before. So this is really empowering, and I really like that they're finally not being dismissed, or they're actually heard and believe that someone is listening to them. I can, imagine that this is very important for those people.
Yeah.
So you've talked about the hypervigilance. How do erroneous illness beliefs or like past negative experiences, for example, like a choking incident, can then create such a cycle of hypervigilance that disrupts normal swallowing?
I think it's a really interesting area of functional dysphagia. This concept of hypervigilance, when we're talking about the oropharynx and the larynx, is really relevant to us, isn't it? If every time we think of that fear, that phobia, that past experience of something going wrong, a choking incident or someone doing something around our throat, if that kicks up a stress and adrenaline response, we know what fight or flight response does to the larynx. We all know what we sound like when we're about to talk in public. We know that the larynx has a really strong airway protector mechanism, and the adrenaline will hit there, and it will hit there hard whether you want it or not. It will reduce your saliva. It will constrict your pharynx and your larynx. It will inhibit your gut. So it's doing all these things that we know you need for swallowing every time someone thinks about the thing that happened, and then it builds into a sort of patterned behavior of it thinking about it again, overly thinking about the food in the throat, and then that leads to this extra response that keeps on happening. And I think if you get negative messages back to your brain saying, hey, it's all closed up, the saliva's dried out, it's really dry in here and things are sticking around, globus, laryngospasm, they're all really common in these patients, then you're adding to the patient beliefs. So now instead of just thinking about the fear of the choking incident they had, now they've got bad memories within the swallow sequence. So they're now in their mealtime and they've been given this like added information that says the meal's going bad, like it doesn't go down. And then of course you continue the cycle. So it's quite interesting if we look at the functional heartburn literature. Functional heartburn is a huge cause of reflux disease and doesn't respond to medicine, so it doesn't respond to PPI. And it's thought to do with a visceral hypersensitivity, so a heightened sensory response to normal acid exposure. So much like the hypersensitivity to the saliva and the feeling of swallowing and the food going down, it's this concept that stress can exacerbate reflux by enhancing esophageal sensitivity to acid exposure that may be the same thing that we're seeing in functional dysphagia of the oropharynx too, a central modulation and a peripheral, perhaps, response that leads to hypersensitivity. So I think it's a really interesting field of exploration in functional dysphagia.
Yeah, for sure. It's very interesting. And looking through this lens of functional dysphagia, I guess it only makes sense to then also adapt the diagnostic process as a clinician. What would you suggest? How should we change our physical swallow assessment and move on to assessing also other things, the ABCs, for example? Could you explain that?
Yes, I think if we stick to our more traditional oromotor examination and oral trials or mealtime observation, we're going to miss part of the problem. We're going to miss some of the parts of the picture that we need in order to treat the patient's full biopsychosocial parameters. The ABCs are a common psychological approach to understanding behavior and understanding behavior of the current environment that's maintaining the behavior. So rather than the SLT, the speech language therapist, trying to change behavior in isolation, it encourages us, the speech therapist and the patient, to understand why the behavior is happening. So A is the triggers, what happens before the behavior. So maybe the fear, the memories of a previous event, the increased adrenaline perhaps. B is the observable action. So what do they do? Do they clench up their throat? Do they hold in their mouth? Do they refuse? And then C is what happens immediately after the behavior. So are there reinforcements? Are there changes in attention that they get? Does it help them to avoid perhaps going out? So are there some consequences that need to be attended for if we're going to truly change the swallowing problems that they're having? So it allows you to tailor your therapy to that whole patient's presentation, not just one part of it.
Yeah, thank you. And you've already mentioned that when people are, for example, having a drink or when they're more tired, then the swallowing becomes better. And I guess it makes sense when we're talking about the hypervigilance, then people are probably not focusing as much on the swallowing anymore as before. How can we as clinicians then use this during an assessment?
Yeah, I think distraction is very well known in functional speech and voice disorders. There's a lot of sort of masking with noise, white noise and things like that are tried to help trigger better voice or speech and fluency. And so I think we can try and use those sort of tricks in our therapy too. It's a really common clinical psychology approach to phobia, to shift attention away from the feared experience in order to try and reduce that fight or flight response. But interestingly, I think it also allows us, if we can get some distraction in, to then get the graduated exposure that we want. So if we can distract, we can feed. And one of the problems we have with these patients is if they won't try something, how do we help them move on? So I think distraction in therapy and distraction at home is really sensible. I often get patients to eat while reading their emails in the morning or while making a cup of tea for somebody else in the house. So trying to get them doing a task at the same time as they try something, or to leave things around the house that they might try by accident, and just sort of hoping that we get some opportunities where they get to taste something and then they've got self-empowerment and self-belief because they did try it and it did work, which means we can put it on their foods they have successfully eaten list that we would use in order to empower and make them feel like they've really moving on. That's one of the foods I know I can do because I did it, remember, in a therapy, or I did it last week when I was making that cup of tea.
So you can also be a bit creative as a clinician in this phase. All right. Moving on to the treatment, how can techniques that are typically used for muscle tension dysphonia, like, for example, a circumlaryngeal massage or resonant voice therapy, be applied to functional dysphagia?
It's an interesting one. I think muscle tension is a really common feature of functional dysphagia, and I'm sure you know there's been a few papers talking about muscle tension dysphagia. So it is it's something we've noticed in our patients, and it's a really relevant part of that biopsychosocial framework for the patient. It makes sense that stress leads to muscle tension. So if we reduce tension and reduce stress, we should get better muscle function. So personally, I'll often do stretching, massage, relaxing before someone does their oral intake, some yawn sighs to reduce the laryngeal heightened sort of response. So just trying to get them into a place where they are in a better muscle state before they're going to swallow. But there's been a couple of papers that have gone beyond that and really moved into what we would typically use in voice therapy, semi-occluded vocal tract exercises, breathing exercises, resonant voice therapy. I've never tried resonant voice therapy. I have tried semi-occluded vocal tract exercises with good effect. So I think anything that's going to open up the pharynx, relax the larynx, relax the pharynx is going to be useful. And then you have this terrible challenge that you've got to do all these things to set the scene, but you also want to distract them from the thing you're then going to make them do. So you don't want to do so much that you've sort of been winding them up to the moment where they're going to swallow something. So I think it's always quite a fine art between doing things that get them into a good place without overly thinking about the meal time for ages before, and then making them even more stressed. So it's a perfect balance when you're working with these patients between doing something that's right and tipping over and doing something that adds to hypervigilance and adds to worry.
Yeah, and I guess there's this risk that if we do those exercises before, then they get used to them and only will eat after having done those exercises. May this be actually a problem?
Oh, that's such a good point. And I've definitely gone wrong with patients where I've accidentally added more compulsive behaviors. So I think you're quite right. It's something we have to be so careful with between things that empower, enable, and make people feel confident and successful. So allow you to achieve goals that they didn't have before, but without the risk of adding more compulsive behaviors that are really difficult to withdraw. So it's a tricky balance that you have to get right with each patient. I think that sometimes you can end up with things that you then have to withdraw as well. Yeah, they're very challenging patients to work with, but really enjoyable.
Yeah. And are there any different strategies for clients that have a hyperactive gag reflex or chronic cough as part of their functional profile?
Yes, I think heightened sensory responses to swallowing are really common, and they do sometimes come alongside a globus, chronic cough, throat clearing sort of route. Sometimes I've had patients that gag the moment they put things in their mouths, so have a real sensory gag response. And the way I've treated that is working with them as if I would a chronic cough, hypersensitive larynx sort of patient. So using that sort of multifactorial therapy approach that we would use with those patients. Occasionally, ENT have put them on neuromodulators, but I would definitely be working on sort of cough or response substitution. So trying to change that gag, cough, throat clear to something else to try and break that cycle. Lots of psychoeducation on what is a normal throat clear and did you really need one there? What would happen if you didn't do one? Do you think you could try? Just to try and counsel them out of some of those behaviors. Reducing all laryngeal irritants, so trying to avoid things that would make the larynx more angry, and really setting sort of small, good goals so that they're moving forward through graduated exposure. Sometimes I find I've had patients who have been so long without any solid food, it's really hard for them to tolerate that experience. And so we'll graduate through from thicker to thicker from their fluids, or one mouthful before you take some fluid. So like that balancing act of, I've got to get rid of the sensitivity somehow, but I've got to do it in a way that you can tolerate. So that sort of gradual exposure to try and break the cycle of every time you get that exposure, this is what happens. So trying to break that cycle is really important.
That's very interesting. Thank you so much for all your explanations. To close up this episode, what is your primary advice for SLTs when they encounter a patient who has been told that there is apparently nothing physically wrong with their swallow? What do you think is the most important thing, maybe also to start working with these patients?
Yes, it's a great question. Sadly, most of my patients still come to me that way with negative results rather than a positive diagnosis. So I would advise that people focus on the positive signs of functional dysphagia, ensure that physical, structural, neurological investigations have happened first. I think patients need that reassurance, but so do we. Globus is only globus if there's not something there. So we do need to rule out other causes of a feeling of something sticking in your throat. We can't risk missing a structural abnormality, a tumour, a diagnosis that would be treated differently. And then I'd recommend people just map out that predisposing factors. So what does that patient have in their history that could have triggered this to occur? What does their swallowing look like now? So what are the behaviours that they have now that we will need to address in therapy? And what potentially are those perpetuating factors that we also need to consider? Their avoidance, their perhaps consequences that add to secondary gain. So perhaps some consequences that have been convenient. So avoiding returning to work or getting attention, family dynamics changing. Sometimes there is a more complicated sort of reason why it's staying, and using all of those bits together to try and plan a therapy and plan a team that's correct and right for that patient. And then we can give them therapy. Speech language therapists have a lot of the skills that these patients need. I mean, I would say, this is a team approach. It's not just us working in this field. I regularly work with clinical psychologists. So I think it is important to bring the right team together. We don't have to do this on our own, but some of these patients we can manage on our own. I have needed to work with chronic pain specialists, so chronic pain specialist doctors and physiotherapists, and psychologists regularly with different patients and different problems. But we're a really critical team player, and we've got a lot to offer these patients. We've got a lot more of the counselling and psychology skills than we think we have, but also with this motor sensory aspect to functional dysphagia, I think we really bring something different to the picture that they wouldn't get from clinical psychology alone. So I think we can be a really valuable team player.
Thank you so much for sharing. Maybe this helps many students and also already clinicians to dive into that topic even more.
I hope so. Thank you for letting me talk about it. I think it's a really valuable thing for us to talk about more.
Absolutely. Thank you. Thanks so much for listening. If you enjoyed this episode, leave a review wherever you listen to podcasts. You can connect with us on Instagram, LinkedIn, and Blue Sky, or visit our website, dysphagiamatters.org. We'd love to hear from you. Until next time, take care.